So I'll say that it's really interesting to hear the discussion. I come from Canada, where we didn't have access, and so I relate to a lot of what was said. And I've been here for under 2 years, and I'm not a quick adopter to technology, but this was easy to adopt. And so I will hope to answer the question that I was tasked to answer. When, how, and why do we use fluorescence-guided surgery in colorectal surgery? And following the last talk, I think it's laid out, but we'll go through some of this again. My only conflict of interest is a teaching honorarium for Johnson & Johnson, and it's unrelated. So as I look through the literature and as I talk with people and get more interested in fluorescence imaging, you see lots of applications in colorectal surgery. But I was tasked, thankfully, with routine use, which is the only thing I know a little bit about. And routine use really is anastomotic perfusion, as we've been saying all morning. The other one that is kind of becoming routine, even though it's not perfect, is ureteral identification. And perfusion for anastomotic assessment, it comes very close to colorectal surgeon's heart, so I'm trying to answer the when, how, and why. There are patient factors for sure for anastomotic leak, but perfusion we know is one of the technical factors, and we know that we're not perfect at it. And more on the why is that anastomotic leaks are just too common and too costly. We all know that they have a domino effect of morbidity and even mortality. They really impact our patients' overall quality of life, and we've worked on that, and I'll tell you a little bit more. They escalate cost and resource utilization, I think, more than all these cost-effectiveness studies really capture. And then they have a really bad impact on us, the surgeon, and I think that probably motivates us as well. And just because we've been sharing a lot of data, I added some qualitative research work just to place the why really clearly. This is a patient said, the leak itself contributed to my anxiety and my anti-anxiety medication now. My anxiety going to any doctor or specialist is really quite high because I'm not a very forceful person by nature, and so advocating for myself when I was so ill with the leak, it was very hard. And then from a different paper about second victim for us surgeons who have to deal with the anastomotic leak, one surgeon said, I grieve for how badly it makes me feel. A piece of me is being taken away with this complication. So I don't mean to be dramatic, but I'm not a quick adopter. And when I came and saw a technology that I think could really help me and help my patients from this misery, there was a big why. The data didn't, it's interesting to know the data, but this why meant a lot to me when you balance it with all the feasibility aspects of adoption. The evidence was really nicely reviewed, so I'm not going to dwell upon it. A systematic review published this year, as was eloquently said, was supportive, and these were predominantly all colorectal anastomoses or low anterior resections, but this did include retrospective data, and it was supportive with almost a half reduction in anastomotic leaks in the ICG group. However, we know that retrospective data is probably not as reliable, and so meta-analyses of just randomized control trials would be, I apologize, these are trials, all randomized control trials. When you look at just the low anastomoses, it didn't quite reach statistical significance, but clearly it's a sample size issue. For the naysayers, there were 2 randomized control trials that were negative, and I agree we need to look at the details of the trials to understand them a little bit more. This is a trial coming out of the Netherlands with 900 patients, and if you look at the left-sided group, that's where you saw a statistically significant and clinically relevant reduction in anastomotic leak of 6%. This trial was just published a week and a half ago, and it also had a negative result, but I echo looking at the details. So in this trial, there are over 1,000 patients, and half of them were right-sided colectomies and half were left-sided. The anastomotic leak rates were very reasonable, under 10% in both rights and lefts. But looking at this data, about half the surgeons had less than 10 years experience, and half of them had not done more than 50 colectomies, which our residents should have done more than that. So that's different than us in our practice. And the change in anastomotic site was significantly different at 7% in the ICG group compared to 4% in the control group. And when you look at the anastomotic leak for left-sided, you see again almost a halving in the leak rate at 5% compared to 10%, not reaching statistical significance. Again, as was mentioned before, that here they didn't control for how long you looked, what angle you used the camera in, and all these details. And the surgeons in this study, this was their first time using ICG in the study, according to the paper. So we have to take it with a grain of salt. And they concluded that it may be beneficial in left-sided patients. So routine use is growing. The evidence will get better and will still continue to accumulate, but I think a lot of people aren't waiting for a perfect randomized control trial to be published to adopt this technology. I think the ship has already sailed, and I think rightly so. And a lot of it is because of the nice features of adoption. So in Canada, what we were planning there is as we came to upgrade our systems, we would upgrade our ORs to systems that had ICG capability, immunofluorescent capability built in. And then you have, it's a reusable, predominantly reusable equipment. Safety is clear, and I'll show you consensus data about the safety and that the adverse reactions and this idea of allergic reactions to the very minimal iodine is almost nil. And the ICG itself is affordable, and that was already discussed. And finally, it doesn't add much time to your procedure at all, and in a systematic review, it added about 6 minutes. Cost effectiveness was looked at in colorectal surgery by Chris Schlachta's group in Canada, and they found that if you estimated about a third reduction in leaks, so that's a pretty fair, moderate assessment in their decision tree analysis in all different respects, you would save about $400 plus in all colectomies. And I'm sure the cost savings is more. So to increase the whys, yes, there is evidence, it's growing, it's becoming more robust, but it's already been adopted into guidelines, as was said. So the European Society of Endoscopic Surgeons have already adopted it in their guidelines, and we reviewed this very nicely in the last talk. And they are recommending it, even saying that it's strong evidence, despite the fact that I think the evidence is still growing. But they say that ICG fluorescence in colorectal surgery to assess tissue perfusion is recommended in order to reduce the risk of anastomotic leak. Here in North America, as colorectal surgeons working with the American Society of Colon and Rectal Surgeons, we feel very strongly about anastomotic leak, and we feel that they're underreported. These leak rates of 5% are probably not true leak rates. When you look at NISQIP data, anastomotic leak rates are about 4%. And we know that the anastomotic leak rates for left-sided and colorectal anastomosis are probably in the order of 10 to 15%. And a lot of that is due to poor reporting because we don't want to report them, at least here in the United States. So we put together this framework, and this is work funded by ASCRS. And again, we based it, like many of the other guidelines, on grade methodology. We had a great team of trainees, we had international experts, and we collaborated with 6 international colorectal societies in the world. And we did a complete literature review of all meta-analysis systematic reviews, and we included randomized control trials that were not included in systematic reviews. We had patient partners and got the patient perspective, and expert opinion weighed in. And this is how we came up with our statements. So this is our systematic review. These are our trainees who we owe all the thanks to. And we came up with a framework that included 6 preoperative statements, 9 intraoperative, 6 postoperative, and 6 long-term statements. And I'll just focus on the intraoperative statements because that's what's relevant here. An intra-op perfusion assessment came out in systematic review, including only meta-analyses and randomized controlled trials, to be strongly supported when we looked at the data. And then when we brought it to the expert panel, 3/4 agreed that perfusion should be included in the framework, and colorectal surgeons should be asked to assess perfusion when they're reporting on an anastomotic leak, whether they used perfusion or not. and this has been now published in Diseases of Colon and the Rectum. It should come out next month. And it's included with such important elements as using a diverting stoma appropriately, and checking your anastomosis for integrity with flexible sigmoidoscopy, mobilization of the splenic flexure to decrease tension when appropriate. So this is a big move forward, at least in the colorectal sphere here in North America, to tell surgeons, please think about perfusion. It's time, it's here, it's now. And it will be like an element like this in the framework. When you report on your anastomotic leak, did you assess perfusion? Yes, no. I feel this is a good push forward. So for the how, I mean, I learned it from all of you, so I think you all know how, but typically in our OR, we do use the 25 milligram vial. The anesthesia makes it up for us in 10 milliliters of sterile water, and we push about 3.5 cc's with a 10 cc flush. And we usually see the visualization within 30 to 60 seconds, and it goes away pretty quickly. The optimal assessment is 1.5 minutes to 3.5 minutes based on consensus, and the optimal distance is about 5 centimeters. And I'm really a new adopter. I'm learning all these little details I learned from the residents. I asked them, like, so how does Dr. Wexner do it? Just show me. And I think I got the right feel for it. We typically in our OR do it before and after the anastomosis, so we give 2 injections. This is a nice snapshot study coming out of Italy. They asked 44 centers where they were at with adoption, and 78% said that they are using it routinely when the case is laparoscopic. However, if the case is open, only 40% use ICG in open surgery because of the availability, of course, of the camera and the cost of the camera setup, where it's built in a lot of the laparoscopic sets. And there was no agreement in this snapshot study on how to dilute the ICG, the dosing, and the timing. However, most of the surgeons believed that this technique will become a minimum requirement for colorectal surgery in the future, and I think this is here now. And you see here there are consensus about dilution, ICG dosing. We're getting there. I think more and more there's at least 50% agreement on most of the strategies, and the timing of the injection as well, and assessing before and after you make the anastomosis. At least 50% have agreed on that. The other aspect, this is from Ronan Cahill's work in the lab, is really the how close you are to the object, so being at around 5 centimeters and being at a 90-degree angle, and using a 0-degree scope as a 30-degree scope diminishes the view. All right, the second use is ureteral identification, and though we feel very strongly about anastomotic leaks, injuring a ureter is pretty rare, but shouldn't happen. And if identified in the operating room, of course, saves the patient a lot of morbidity and perhaps loss of that kidney. So we typically, in cases that we know are going to be hard, we use ureteral stents, and can ICG be used? The current evidence right now, the latest systematic review, it's all retrospective data. There are no trials. But with the use of stents or the use of a stent just to access the ureteral orifices and then push the ICG up, that's been done in several studies. There's 100% ureteral identification. And there's no added risk to stents alone. So it's a strategy that many colorectal surgeons are adopting in their practice, and we use routinely in our OR. So the way we do it is we still keep the stent inside. We don't use it for all cases. We use it for cases where a stent is required. It just adds for visualization. We inject the ICG through the stent, and we use about 5 mils at the same concentration as we would for perfusion. And it really stays for the entire case. We also flush it. And I like to operate in the overlay mode, because then I can see and operate, and then you get to see the beautiful green as you work. So here we're lifting the inferior mesenteric artery up, and you see the retroperitoneum. Even with a stent in place, it's not readily obvious where the ureter is. Before we ligate the inferior mesenteric artery, we really need to know where the ureter is so we don't pick it up and ligate it as well. And so here you see it appearing as we go into overlay, and it's just beautiful. It's right there. It's obvious. and you can trace it all the way into the pelvis as you see being done here. And many times, if it's a tough case or there's a lot of adiposity, we can keep an overlay and do the procedure in overlay, and you see the ureter as you're working. And here's the inferior mesenteric artery. We're just going to skeletonize it before we ligate it. This is a consensus that Dr. Dipp, Dr. Rosenthal, and Dr. Wexner completed with 35 international experts looking at the routine use of fluorescence in colorectal surgery. And it was a 2-round online modified Delphi, and they achieved consensus at 70%. And I'll just highlight a few things. The notion that the allergic reactions are really rare and that this is a safe drug to use, they unanimously agreed about. And the fact that it be used routinely for perfusion assessment in colorectal surgery, as well as for ureteral identification, was also agreed about, whereas looking at nerve preservation and lymph node yield and lymph node mapping was not yet agreed upon, as there is not enough evidence yet, and evidence is still developing and technique is still developing. And then for the technical aspects, like the Italian group, we are starting to reach consensus on the timing and administration, as I mentioned, and we're following these principles in what I stated. And finally, and most importantly, I think the consensus agreed that it's here to stay and that we will, in the next decade, be figuring out all these dosing and technical aspects, but everyone agreed that it's here to stay for colorectal surgery. So perfusion assessment and ureteral identification are really what's routine use. Dosage, concentration, the routes of administration, assessment time, and quantification is being discussed, as well as other fluorophores that are available in the urine directly are probably coming in the next few years. Thank you very much.